Hi, Linda.
Hi, long time no see.
I know.
How's life?
Great. Where have you been all my life?
Where's Mr. Peter?
He's right there. Right? He's on the bed. I'm trying to hide my dirty laundry.
Hola, Vero.
Hola, Vero. Did you see the invite? I didn't realize this was a many hours long thing. And the Fred from Louisville is giving a talk on ultrasound guided regional anesthesia.
Vero, she's talking to you. I don't know
Vero.
if she's working today.
Veronica Sepulveda.
Did you hear what
Beth!
she say?
Did you hear what I said?
You said something about Fred.
Yeah, he's giving a talk after this one about, I think, nerve blocks.
In the same link?
I think so, yeah.
Ooh.
You can stay and hang out.
I'll stay on.
Not because of us.
Thanks, Vero. Thanks.
I love you guys. You guys are awesome.
Oh, no, there's another link. I'll send it to you en el chat, Vero.
In el chat.
In the chat. Dale. Send it to me in the chat.
Yes,
Okay.
madam.
Bye-bye.
Lily and Beth, just give everyone to like 105. That's when usually most of us join in, and then you guys can start.
Perfect.
Good afternoon, everyone, for joining again this week. So this week, I'm glad to have Lily Morales-Perez and Beth Yamiko from the Global POCO's webinar coming to present cases. So I'd like to thank them for, because I think it's in the morning for you guys. So thank you so much for coming to join us, and you guys can take it away.
Thank you so much for the invitation. We're super excited, Beth and me, to join you guys. We've been coming to your sessions and we've been having fun learning about all the interesting cases that you guys see in your institutions. For those of you who don't know us, like Henry said, my name is Liliana Morales-Perez and my partner is Beth Amico. We are both pediatric emergency medicine, global health, and POCUS, and we travel and have done some educational projects abroad, and we have encountered very interesting and odd cases. I think that's a good way to put it. And today we're going to be sharing with you guys some of the cases that we've seen that we thought we could all learn a little bit or get surprised with together. I'm in Puerto Rico right now. Beth is in Cleveland. So if you see roosters that's on here, roosters that's on my end, I apologize. Their clocks are not.
Hey, Denver.
They're not following protocol. So today we're going to be talking about some cases we've seen in Panama, Malawi, and Puerto Rico where we've ultrasounded together. So we're just going to review the utility of POCUS to help diagnose and manage sick children in resource-limited setting, and then talk a little bit about some interesting infectious or endemic diseases cases that we've seen in these places. Please feel free to interrupt us and ask us questions and comment on the ultrasounds and all that stuff.
Okay, I'm going to start. And yeah, this is probably better if you comment or type in the chat box. You can comment on the quality of the images. Sometimes we are not sure what we're looking at and we go back and we're like, wow, that was a really great image, or oh, wow, that was a really terrible image. Why didn't you image that a different way? So we're open to all commentary on the images and the cases. So I'll start with the first case. This was a patient from Panama, so from the Tertiary Children's Hospital in Panama City. It was a patient who was in the ICU when we were there on one of our teaching trips, who was in the ICU for septic shock, so was intubated. The history was a little sparse, but had had a fever, and prior to coming to the hospital had been limping on the right side, and the blood culture was positive for MSSA. And so these were images done by the docs in Panama. So they're pediatricians who are working in the emergency and ICU setting. Oh, whoa, wow, yeah. So you can see
cool.
That was really cool. You can see pretty easily on that right side where the kid had been limping that even though they didn't measure it, you can see the measurement on the side that there's a nice right-sided hip effusion. So great. We think we probably have our source there for the MSSA. And
we love arrow signs.
That was great. I don't know how you did that, but that was awesome.
Was this done by the providers there or by the radiologists?
No, it was done by the providers. So they were using a butterfly that we had loaned to them, and so they had saved these images.
So we had done a couple days workshop, and then we left a butterfly, and they would scan, and we would give them feedback.
And like I said, the patient was intubated, so they were assessing for pleural effusion. So you can see both sides. They had some pretty nice images as well. And then they also sent us these images. So this kid is clearly pretty sick. Nice pleural effusions on these. I don't know, the frame rate is a little bit off, but the function looked pretty good to us when we saw these.
So pericardial effusion.
And then the question they had, I think at the time was, how concerning were these images for tamponade? I'm sure we've all been in this great discussion about whether tamponade is truly solely clinical plus ultrasound, only ultrasound diagnosis. So I don't know if anybody has any thoughts looking at these. Again, it's a little bit hard to tell. You can't see the valves that clearly, and the frame rate is a little bit off on my, but I don't know if anybody has any thoughts that they want to chime in. If you were consulted over the internet about tamponade.
Across many waters. I guess everybody feels the same way.
Yeah, I mean, your apical 4 seems like the right ventricle has some pressure there, so I would be concerned about tamponade. So as Lei Chen said, that needs to be taken out in the water.
Yeah, so just a reminder, so if you can see the right atrium, kind of early systole, you would be looking for some collapse. That's more sensitive is my understanding, but looking at the right ventricle. So Steph Leung taught us the man jumping on the trampoline in diastole and end diastole. If your pericardial pressures are higher than your end diastolic pressures, then you're going to see that scalloping. And so, yeah, we thought it was consistent. The doc sent us, was this the one they sent us a video doing the pericardiocentesis, and they got a lot of like bloody purulent fluid out. So I don't think the patient was crashing, but they did tap this and it was consistent with MSSA infection. So they're very procedure oriented. They use their ultrasound for procedures quite a bit and had no issue doing a pericardiocentesis at the bedside. So
I think it also helps when you have that large effusion.
Yeah, yeah.
What was their approach? Was it like subxiphoid or just go at the biggest area?
No, I think they went subxiphoid. I know they sent us some images with measurements. So they were kind of trying to see where the biggest pocket was, but they did go, I think they go subxiphoid most every time. And so then we saw another case in Malawi that was possibly, we'll say possibly, another disseminated staph infection. So this was a 9-year-old who presented with abdominal distension and had been taken to the OR for laparotomy by surgery, and apparently had some pus drained out of the belly, and then was back in the HDU, which is kind of like their ICU. And so these images were sent by one of the clinical officers who's kind of like would be like a PA level here, working in the ICU that we had trained, and he also had a butterfly over there. So these are just still images of the right lower quadrant and left lower quadrant with some funky looking fluid collections. And then these were suprapubic images that he sent, which also look a little concerning for some fluid collections or complex collections. We didn't really know what to make of, if you go back, on the right side image, all the material sort of underneath the bladder. We're presuming that was kind of pus and fluid, but it looked a little bit weird to us. And then he sent us these images. So this patient also had a pericardial effusion. This patient, they did not do pericardiocentesis, but they had a decent size effusion as well.
I think Dr. Chen was commenting on the chat that asking if with the pericardiocentesis they hit the liver. He says that in his experience, half of the cases of pericardiocentesis result in a liver lag in Rwanda. So he was wondering if in Panama it happens as well. I guess they haven't, the doctors, the physicians in Panama haven't commented on that particularly. Also, we haven't asked if the kids had resultant liver lag. I definitely will ask from now on, but they usually do have successful procedures. I don't know what the complications hitting other organs is. I don't know, Beth, if you have a different experience with that.
No, Yeah, they usually go subxiphoid, but they've never commented like that they had any excessive bleeding, although it seems like that would definitely be a risk.
So we've seen unsuccessful pericardiocentesis abroad and thankfully have not resulted in significant liver lags. Also, if you don't ask, they don't tell you, I guess.
That's true. So that was kind of an interesting case from Malawi. Presumed disseminated staph. So this is a really wordy slide just to say that Staph aureus is a common bloodstream infection, both hospital acquired and community acquired. Hospital acquired, we see more here in the States. Risk factors are kids with congenital heart disease or hardware, and then central venous catheters. And then community acquired usually results presumably from nasopharyngeal carriage or from musculoskeletal infections kind of seeding the bloodstream. There are some studies that show that there's a significant risk of complications for every day that it's not treated, particularly with MRSA. There's not a lot of literature in Panama. There's some from Argentina that talks about a significant burden of MRSA, but those countries are not that geographically close. And then Malawi, we don't know anything about MRSA really. And then the IDSA Society of America, just for sort of our practice, does recommend echo for kids with Staph aureus bacteremia who have congenital heart disease, long persistent bacteremia, so more than a few days duration, or clinical findings of endocarditis. So.
And when we were working in Malawi, there wasn't blood cultures to be drawn, especially in the sick kids. So it's mostly clinical if we think that patients have bacteremia. I think this particular patient probably had some skin findings. Like you guys could see on the images, there was a lot of superficial sort of fluid. So we don't know if that's how they came up with staph or if this patient actually had a blood culture resulted, which would be very rare in those clinical settings. So moving a little bit from Panama and Malawi to Puerto Rico, this is a 14-year-old male patient with a history of Kawasaki disease that was diagnosed when he was 3 years old. He had coronary artery dilation and is on aspirin and Coumadin. He presents to the ED with sudden onset of chest pain, 10 out of 10 substernal crushing that radiated to the left side of his chest and his left arm. The last INR that was checked was about 3 months previous, and it was around 1.3. Mom said because of the pandemic, they haven't been checking his INR as they usually do. So this is this initial X-ray because, you know, every kid that has chest pain, we get chest X-rays. And this is his EKG. Does anybody want to comment? Thankfully, this is all in Spanish, right? So you guys can understand it. Normal,
Yikes.
not normal.
That looks bad.
Not normal.
Yeah, not normal.
Something odd somewhere. So thank you, Alicia. So we see some ST depressions in leads 2, 3, and AVF. And we also see some ST elevations, V1, V2, VR. So we're not cardiologists. Not normal sounds great. So we did a cardiac ultrasound.
That's a really high quality machine you have there, Lily.
So our machines we are unable to export. So this is a sonocyte and this is an iPhone video of the sonocyte. So it's a double whammy. What do you guys think? What is wall motion abnormality? I agree. Okay, so we see this left ventricle, the contractility is not really good. We see that mitral valve opening is not really hitting the septum. So not good. So this is our short axis. Anything in particular that jumps out to you guys? So we have our left ventricle, our right ventricle, looking at the squeeze of the left ventricle. Antonio wrote caca, I agree. So not good. Pitiful squeeze. Perfect. Thanks, Alicia. Okay, so and this is our 4-chamber. Again, I apologize for the image quality. This is what we can do. Beth is going to set up a GoFundMe so I can get a better machine that can export.
Yeah,
So
it's still
here
pretty impressive, even though the images are not like.
we still see poor cardiac contractility. So then this patient has a history of Kawasaki. So I attempted to look at the coronary arteries, right? And coronary, you know, it's difficult looking at the coronary arteries with a machine like the Sonosite. But if you guys can see and imagine it, maybe we can see a coronary here. This is a still image of sort of the diameter of that coronary. So not the scope of our POCUS practice, but trying to see if we can correlate patient's history. Oh, sorry.
Lily, quick question. Would color help to identify the coronaries?
It might. I didn't try, but it might be a good idea. Usually when I'm looking at the coronaries, I'm just trying to see if I can see them. If I see them, I'm like, that might be dilated because usually I can't see them. But in this case, you could definitely see the coronary coming out. And I tried to take just a still image so that we could capture the diameter of it. But we are very focused on not changing lanes into cardiology. So it was just more educational for our purpose. Okay, so we got labs, and these are the relevant ones, right? Troponin of 6.3 and a lactate of 64. So what do you guys think is going on? Don't let the age fool you.
Yeah.
Absolutely. So this is what I wanted to do when the patient was in the ED. It's like, I am not an adult ER physician. This is not what I'm used to. So patient with a pediatric MI. So one of the interesting things looking at POCUS on patients that have MI is trying to look at regional wall motion abnormalities. And it's not a thing that we get to do very often because thankfully, and I hope that it stays that way, we don't encounter patients with pediatric MIs. So looking at the distribution of the supply, the coronary arteries into the heart, we see that the left coronary arteries are going to be mostly in this beautiful image that core ultrasound has. So you see in the interventricular septum in these areas. So it helps us with the color. And then the right distribution, the right coronary artery distribution is going to be in this side. So looking at our POCUS, comparing it with this distribution, what do you guys think the injury might be? What areas of this heart? Now thinking about that, because usually we don't.
Yeah, someone
Right,
said
though.
LAD. Yep.
Yeah, absolutely, right? So if you look in this distribution, the interventricular septum barely it's the part where that's barely moving, right? You can see some movement of the left ventricle here, but this interventricular septum is the part that jumps out of you, that the motion is abnormal. So the patient had an echo that showed dilated coronary arteries, hypokinetic interventricular septum and right ventricular apex, and diminished left ventricular systolic function. So sort of the changes that we saw with POCUS. So the patient was admitted to the ICU. He received TPA, and that's when I was running. I don't know how to do TPA, so I dumped the patient in PICU. They gave it there quickly. The EKG changes and troponins improved after the patient received TPA. So this is the troponin trend. So initially it was 6, then it bumped almost to 12, and then slowly started decreasing. And this is the lactate also started very high at 64.6, and then it slowly improved. And after the initial stabilization, the patient was transferred to the CVICU. In the CVICU, he had a cardiac cath. And as you can see, the patient had severe stenosis of both left and right coronary arteries. So I think this drawing helps me a little bit more than the cardiac cath. So the patient had a severe dilation secondary to his Kawasaki on both distributions of the left coronary artery and the right coronary artery. And then after the severe dilation, he had severe stenosis, more than 90% stenosis in both coronary arteries. And a fun fact that I did not know, because again, I'm a pediatric doctor, when patients have Kawasaki and that have dilation and stenosis, that is one of the contraindications to put a stent. So this patient underwent CABG. So he had 2 coronary artery bypass grafts and was discharged home with cardiac medications, but persistent decreased cardiac function. So it's not that common to see pediatric MIs, but POCAs can really help us identify the extent of the injury and how quickly we have to move. Because I think we all do cardiac POCAs on patients with chest pain, never expecting to find this. And even if we have some EKG changes, I don't think I've ever had an MI before. Have you, Beth? No.
Never.
Anybody else have an experience with running from the fire that is a pediatric MI?
Luckily, there was a cardiologist that was there because it was suspected. But I had a couple of questions with this case. How long did did this patient have Kawasaki disease?
So he had Kawasaki when he was 4 and he's 13. So 9 years.
And so they thought the changes were still present at that time?
So he had the coronary artery dilation with the Kawasaki. So I don't know if he was adequately treated at that time or if he was late to identify that he had Kawasaki. But he had been followed by cardiology. That's why he was on Coumadin and aspirin, because they knew he had coronary artery dilation.
When was his last echo, like from CARDS follow-up?
Before COVID. The last time the patient had seen his cardiologist was before COVID, and the pediatrician was refilling the Coumadin.
The last ones, I was like, any tricks to get into coronary artery? I usually don't have the best luck on getting those used, just because, I don't know, it seems hard.
Yeah, agree.
Fancy machine.
Fancy machine. Okay, so our next case, also from Puerto Rico. This is an 8-year-old who was in his usual state of health until a week prior, when he began with fever and diffuse abdominal pain. He was seen at what we call the CDTs, which are the local centers of diagnosis and treatment, where he was diagnosed with a viral illness. The patient had continued with persistent fever and abdominal pain, and during the second evaluation was found with thrombocytopenia and altered mental status, and was transferred to our institution due to suspected dengue fever. So on arrival, the patient was not febrile, but had tachycardia, tachypnea, and hypotension. Beth, did he have hypotension?
Wow, that's some hypotension right there.
So he was hypoactive. He was acutely ill. He had dry oral membranes. He had some crackles. He had retractions. His abdomen was soft, but he had diffuse tenderness. And in his neuro exam, he could follow commands, but he had intermittent episodes of altered mental status. So he would describe things that weren't present in the room at times.
And remind me about dengue a little bit.
I've
never seen dengue.
So unfortunately, I don't have any straightforward case of dengue to present today, but dengue is a mosquito-borne illness that is very common in the in the tropics and especially in Puerto Rico. It presents with like any other viral illness. So you're going to have myalgias, retroorbital pain, fevers, headache, and after the fever goes away, which usually lasts about a week, the patients are going to present with severe thrombocytopenia. If it progresses to dengue hemorrhagic fever, then the patients can present with bleeding, shock, and essentially they get third spacing, capillary leak, and the patients die of shock. So patients with persistent fever and thrombocytopenia in Puerto Rico, we get really concerned about dengue. Okay, so this is the cardiac POCUS we did on this patient. What do you guys think? Better than the MI, I think. Not an MI.
Small effusion. And obviously the squeeze is questionable.
I agree, right? So we saw this pericardial effusion right here, small one. You can see it better on this one. And then decreased cardiac function. The squeeze is not great. That mitral valve open is not close to the septum. So this is our short axis and our subxiphoid doesn't look that great. Again, we can see a little bit of an effusion and decreased cardiac function. This is our 4-chamber and our IVC. So again, we can see a little bit of that effusion, decreased cardiac function, and our IVC is definitely plethoric. So we have a cardiac POCUS that is not normal.
So that's not consistent with dengue.
So dengue should not present with cardiac failure, right? Unless it's advanced dengue. So this is our FAST, and as you guys can see, here's our spine sign. We see some fluid above the diaphragm, a little bit inside the belly as well. And this is our suprapubic views. Also with a little bit of fluid, nothing impressive. So this is his chest x-ray, which to me looks extremely normal. It's a discharge home chest x-ray. That's why POCUS is so important, right? I don't see any effusions. The heart looks great. We still don't know what this is, but everything else looks great. So then we get the labs and we see that the patient has a platelet count of 98,000. So he is thrombocytopenic. His albumin is 2.3. So he is hypoalbuminemic. And that's one of the things we see in dengue. However, when there is capillary leak and hemorrhagic dengue, we are going to have hemoconcentration. So the hemoglobins on this patient should be very elevated. So that really doesn't go with dengue in addition to that cardiac function. So we continue to do labs. And this is his troponin, CRP. He has an elevated BNP, and he has COVID IgG positive. So what do you guys think?
Wow.
Even in Puerto Rico. So not everything is dengue, right? So this
Yes.
patient has MISC. And thinking about that altered mental status, they discussed with neurology and recommended an MRI that found some lesions in the splenium of the corpus callosum, which I Googled to see where it was, and had lesions that were consistent with cytotoxic. And we've seen that in viral illnesses or autoimmune illnesses, and it's actually seen on patients with COVID. So another component of the physical exam and presentation that should alert us that the patient might have MISC. So this is his x-ray a couple of days later. So this x-ray looks more consistent with what I would have expected of this patient. And we've seen the troponins started trending down and the BNP as well as the patient received treatment. So he was on IVIG, steroids, and inotropic support in the ICU. His cardiac dysfunction improved, his mental status improved, and he was discharged home with cardiology and neurology follow-up with actually good mental status, a repeat MRI with resolution of those cytotoxic lesions, and then repeat echo with better cardiac function. So early identification, adequate diagnosis. Not everything is dengue. Even here, the patient had a good outcome.
Lily, how often are you seeing a MISC in Puerto Rico?
So we have had around 10 to 12 patients. Most of them have not had severe cardiac dysfunction. So right now we've seen more MISC than severe dengue. This season of dengue, although we've seen a lot of patients with dengue, we have not seen hemorrhagic dengue yet. That's why I don't have any new images to show you guys about POCUS findings of dengue, which are very well documented in other countries like India. Maybe for the next time you guys invite us, we'll have some dengue POCUS images. But right now, what we have seen is MISC, and thankfully we haven't seen it as much as they have in other places like Texas Children's.
Quick question. Textbooks tell me that dengue gives you this breakbone fever, or is known as, do they characteristically have more pain than, I guess we haven't seen MISC that before this year, but in your experience, would that clinical distinction be helpful?
So I think that pediatric patients are more resilient or resistant to that than adults. So adults will present with severe myalgias and body aches to the point that they don't get out of bed. But pediatric patients usually are okay. They will complain of pain around their body and not feeling great, but they will continue to do their daily activities even with that. I've had dengue hemorrhagic fever. I remember it hurts, but I was in the hospital running around, so I'm a dengue survivor.
All right. Next case is also from Puerto Rico. This one is a little bit older. And I will say pre-COVID. This is from a few years ago before, Lily, you were the ultrasound fellow. So pre-ultrasound fellowship that we thought was interesting and haven't run across a ton in the literature. So this was a patient, 19-year-old, lovely gentleman who came to the Children's Hospital for unresolved right-sided flank pain and fever. He had been told he had a kidney stone and was treating himself with ibuprofen, but it was not helping. And so he came for further evaluation. And his exam was notable for some tachycardia and a fever and some pain over his right lower quadrant and right flank with some CVA tenderness as well. And so he had some imaging, I believe, in the hospital for ultrasound for appendicitis, perhaps, that was negative with this persistent pain. So Lily went and looked at him again with the butterfly probe, looking at his right upper quadrant. So the image on the left was a longitudinal view of his right flank. You can kind of see the kidney starting out there. And then she sort of moves down and is focusing more on the structure here and sees what looks like a fluid collection in this structure here. Nice striated material, looks like some vertebral bodies underneath. Again, this was a longitudinal view. And so I think that when you sent these to me, I was like, what is this? This is weird.
I had no idea what it was.
So then she did a transverse view of the right flank. Yeah. Yep. Someone commented in the text box. Yeah. psoas abscess. So you can see a little bit of the outline of the kidney. And then again, this fluid collection that doesn't look like it's in the kidney. And there's a still image of it. And then I think you have a couple more images. Looking just kind of focusing in on the psoas muscle, you can see a fluid collection that doesn't have any color flow over it. So yeah, this was a psoas abscess visualized from the right flank. And I don't remember, I don't remember if you recall this patient complaining of a hip pain or a limp or anything like that. I think the common presentation is supposed to be fever and limp and back or flank pain. I don't know if you remember.
I don't remember.
You
No.
don't remember this guy? Okay. So just a reminder of where your iliopsoas muscles are. And in looking through the literature, there's not that much, especially in pediatrics, a couple of case reports, and these were some nicer images that we found. This was from an emergency medicine journal of a case report of a patient who was found to have a psoas abscess. And so they just had a nice picture on the left where you can see the kidney and the psoas muscle nicely defined, and then their patient on the right where you can see the sort of enlarged heterogeneous collection, sort of looks like adjacent to the kidney. So that was a patient with a psoas abscess, an adult. And then, yes, Kate, thank you so much. This was the only thing we could find in pediatrics, looking at psoas abscess, and it looks like visualized from the right lower quadrant. So iliac vessels and then psoas muscle on the left. And then I think it was a young patient, like 4 years old, who had a psoas abscess visualized on the right. And I don't know if you have any comments. I routinely don't look for this in kids who I have concern for like a septic joint, but I don't find any fluid in the hip. But kind of after reviewing this, it might be something I start looking at. I don't know if anybody has any commentary.
Yeah, this I sort of got lucky with. It was a kid who was referred in from their PMD with, I don't think it was, yeah, it was limp. So it was limping and had fever. No, sorry, I can't remember if she had fever or not, but was limping, and it had gone on for like a month. So the pediatrician got labs that were through the roof. The ESR was like over 100. So got sent into the ED. Was sort of a focus on, was this osteo or something else? But she really had full range of motion of her hip, but right lower quadrant tenderness. So I started out just looking for API, and sort of similar to you guys, was like, what is this? And then realized I was looking at the psoas. So I started in sort of a transverse right lower quadrant view, and got that image and sort of put the pieces together.
That's really cool. I think
it's a lot better than my images.
I definitely would have thought, at first glance, I would have thought maybe this was an appendicitis. I probably would have been thrown off, but that's really cool.
Like a perf appendicitis.
Yeah, but it's really interesting.
We're lucky to have these people on this call.
I know. And then this is just another from an adult patient from Life in the Fast Lane. Again, a pretty good image. Okay. Yeah, this is it's on my POCUS bucket list too. Now I'm going to start looking for everybody for psoas abscess. Okay, so next case is a case from Malawi. So this was a patient, there's a high HIV burden there. So it was a 4-year-old sent from our HIV clinic for failure to thrive and weight loss for a couple of months without any symptoms of cough or shortness of breath, and had been taking their antiretroviral. So the team wasn't clear exactly what was going on. We did not have a chest x-ray, so we did some POCUS imaging. It was one of the times we were working there clinically. And exam, we did have some vitals. We probably took them ourselves. He did have a systolic murmur, not that unusual, and some abdominal distension with hepatomegaly and splenomegaly. Again, not that unusual in the patient in that setting. So these were some of the lung images. I can say they weren't that impressive. One of the things that we were concerned about, obviously in a patient with HIV in a setting endemic for TB, was looking for pulmonary TB, but we did not find what we were looking for on these images. There's a little bit of fluid on the left side, but nothing very impressive. So we continued on. Imaging of the right upper quadrant on the left side of the screen and the left upper quadrant. The images of the right upper quadrant aren't that stellar. Definitely wasn't me that took those. I don't know who that was.
There's only 2 people in this thing. It's either you and me. So thanks for throwing me on there.
I'm just kidding. I'm just kidding. This was
okay. Right and left. Anybody see anything odd looking?
The spleen looks like a honeycomb. I don't know. Those basic things that would explain it.
Yeah. definitely. Good pickup. I guess after you look at a lot of normals, when you look at something abnormal, you're like, whoa, that looks weird, but I don't know what it is. So again, this was an image of the left upper quadrant, and then an image of the spleen with a linear probe. And you can see it has this weird, like, I don't know, like there are holes in it or mesh, or not exactly sure. So one of the things that obviously we were concerned about, oh, and this is the cardiac imaging, which looks pretty good. I don't know, maybe there's a small effusion, but I think it was just that we were using that tiny microconvex probe. So one of the things that I was saying we were concerned about in this patient, so obviously we think about the side effect of the HIV medications, we think about infections, in particular PJP, we think about TB. There are a lot of different parasitic and infections we don't have, and we think about things like echinococcus. And in thinking about TB, we didn't see anything in the lungs, but actually the findings that we saw in the spleen were fairly consistent with extrapulmonary TB. And when we were working there, we did quite a bit of reading about extrapulmonary TB. And Tom Heller, who does a lot of research on that, was working in the adult clinic in the Long Way at the time. So who noted the abnormalities on the spleen, that was a great pickup. Those are actually signs of focal splenic lesions found in extrapulmonary TB in kids. And it's pretty specific in kids, particularly when they have HIV co-infection. And so looking for these small dark lesions, the patient on the left is an adult from an adult case study. And then the patient on the right was from a paper talking about using the FASH exam. And so these are tiny little micro abscesses indicative of extrapulmonary TB. So POCUS really helped us in this patient because they were able to get started on TB treatment despite not having any pulmonary findings. So that was a big help to us.
Yeah, and I like that honeycomb appearance. Yeah, that's a good way to describe it. And you might have seen this case before, but we can't do any global health talk without mentioning something like this. So this is a 13-year-old female with increasing cough, shortness of breath, and swelling. She was acutely ill with anasarca. She had crackles. She had a gallop, distended abdomen with a positive fluid wave, and pitting edema ×3. And this is her heart. So definitely not a normal heart. Anybody want to comment on some of the things that you might see in this heart?
And this was a patient, I believe, who had no known medical history. And this presentation is really common, unfortunately, in Malawi. A lot of patients who have sort of edema, and you're trying to differentiate whether this is related to malnutrition versus nephrotic syndrome, which is a popular diagnosis, although most of the patients with edema actually are related to cardiac disease. Yeah.
Good. So you guys are commenting on the huge left atrium. You're commenting on that mitral valve. It doesn't look right. Absolutely. So one of the things we learned that we need to know how to do while we're working abroad is using color. It's not something that we usually do when we're working in the States, but color really helps us, especially with this kind of problem, looking at mitral stenosis versus mitral regurgitation. So this is our short axis view, and you guys can see there's an effusion. We can see a little bit of that D sign. We have that thickened mitral valve. And when we look at our 4-chamber, you can also see that mitral valve abnormality. It's barely opening.
We have a little problem with the direction of the color box.
Yeah.
Did you get the idea?
It's important to know how to do it before you go and do it. It's just a little Google search. And looking at her abdomen, we could clinically identify that she was fluid overloaded. But as you can see, she has free fluid on the right upper quadrant, left upper quadrant, and suprapubic. So of course, like you guys can tell, rheumatic heart disease. Thank you, Alicia. So we have to talk about rheumatic heart disease every time we talk about global health, just because it's so prevalent in many countries abroad. It's the only truly preventable chronic heart condition, and it is not rare, it is neglected. And we know the role that POCUS has in diagnosing clinical rheumatic heart disease and its complications. As we were working in Malawi, it's one of the things that helped us the most was being able to identify this, swollen patients had that differential diagnosis, or narrowing that differential diagnosis that Beth was talking about. And there are characteristic morphological features that suggest rheumatic heart disease that it's easy for us to learn. The hockey stick deformity, like Antonio was mentioning, something looks odd in that mitral valve. So it's going to be a doming of that thickened and restricted anterior mitral leaflet, and it looks like a little bit of like a hockey stick. It also looks like a little dog paw is the other thing that they say. So whichever one works the best. You're going to have commissural fusion. So you're going to see that thickened mitral valve fuse on the ends, and you can have associated pericardial effusions. In that dilated left atrium, like you guys noted, with the thickened chordae and the hockey stick deformity. So this is a classic advanced rheumatic heart disease. Heart. This changes can be subtle and they're progressive. So if we can identify them early and start treatment early, then we can prevent cases like this that have very poor prognosis.
And one of the things we learned actually in working with one of the cardiologists from TCH who works in Malawi kind of full time is POCUS is actually pretty decent at assessing mitral regurgitation. And so if you find yourself in a setting where there is a high prevalence of rheumatic heart disease, even just seeing regurgitation is kind of can lead you down that pathway. So we learned a lot about rheumatic heart disease.
Yeah, MR is the most sensitive finding. So learning how to put that color box in the right spot is going to help us with the diagnosis.
Yeah, and like Dr. Chen was saying, there's not a lot of really great treatment for these patients. I mean, they get treated with penicillin and whatever sort of afterload reduction you have. We were fortunate to have some, I think they had captopril and we had some Lasix, but yeah, depending on your setting.
Yeah, so preventing recurrent episodes of acute rheumatic fever is actually the thing that's going to help the patient the most. So treating them with penicillin for many, 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 many years, and try to treat their symptoms so they don't get to the point where they're this anosarchic and fatigued and their quality of lives are very poor. And we wanted to show you quick cases before we leave, before our time is up. So here we go.
This is guess what the case is. They're pretty easy. So this was a patient from Malawi. It was a 4-year-old with shortness of breath, fever, and lymphadenopathy. And we had a cardiac image on the left and then image of the right or
upper
left
quadrant.
Yeah, with some nice lung in there. We'll take any and all guesses. Yeah, TB. So this patient had a pericardial effusion, which is pretty common finding in patients with TB. Maybe some fibrinous material in there. And then you can see this whole bunch of lung findings. So there are a lot of B lines. There's a consolidation under there, probably some air bronchograms and a big effusion. So yep, this was a patient with TB, pulmonary TB.
So this is a 3-year-old kid from Panama that was bit by a semi-animal and now presents with shock. Guesses. 1 and 2.
Do you have those in Puerto Rico?
No, thankfully. Just have big cockroaches. So this is,
no idea.
Something. So this is a scorpion bite myocardiomyopathy. This is how they call it. So it's a myocarditis secondary to a scorpion bite, a venomous, poisonous scorpion that causes myocarditis that progresses to cardiomyopathy. So the patients present in, this is a video that they sent us. The patients present with shock, poor perfusion, and severely ill. If they're able to be treated early in the course with anti-venom, some of them have better prognosis than others, but it's a high mortality disease. So when you guys are working abroad or treating patients that are abroad, one of the things to consider is the prevalence of these kinds of animals. When we were in Panama, there were 2 patients that admitted at that time with a myocardiomyopathy from scorpion bites. So in those, and that region of Latin America, it is prevalent to have scorpions.
Yeah, don't put your feet in your shoes without checking them. We
So
were
that's-
more excited about the sloths of Panama, not the scorpions, but
So that's the thing that they told us is like, be careful when you're putting your socks or your shoes on. Make sure that there's not a scorpion there. Good. Oh, sorry.
So this was a I think it was a 5-year-old child in Malawi that had abdominal distension. So also kind of looked a little bit swollen, not a lot of other history. This was a right upper quadrant view and a suprapubic view, but the more interesting ones are on the next slide. So these were a left upper quadrant view. I don't know if anyone has any thoughts. So it looks like there's a kidney.
Something. Definitely a kidney.
Obstruction to the kidney with some hydro, and then some, yeah, it looked like there's some obstruction. And then there's actually this pretty large heterogeneous mass-like structure. You can see some normal, what looks like normal spleen, and then this large heterogeneous mass that kind of looks like it may be attached to the kidney, coming off the kidney.
So some type of renal mass, that NOS.
We presume. Yeah, again, caca again. So we weren't entirely sure. This could be infectious. Our concern was in this age of a child, perhaps an oncologic process. So I think sort of high in the differential would have been Wilms. If we thought it was some renal involvement, I guess I've never seen a nephroblastoma, and probably neuroblastoma is on the list, although this looks more like it's associated with the kidney. But regardless, pretty bad finding for this child. There is not available treatment for Wilms at this time in Malawi. They have some treatment for leukemia and lymphoma, but not for Wilms.
So this is a 7-year-old with fever for the last 10 days, also in Malawi. Definitely this heart is going fast. Okay, so what do you guys think? How does anything jumps at you guys in this cardiac images that were performed by our wonderful PEM fellow who was doing a rotation in Malawi, a clinical rotation in Malawi? So we noticed there was some thickening over here.
Yep. Somebody said some schmutz on the mitral and some regurg. Yep.
Absolutely. So we, with this constellation of symptoms, we think it probably was endocarditis. And if you can see it, here is a 4-chamber view. You can see it a little bit better in this area. Good.
Good job, Justin. And then we can make this one our last one. So this was a patient in Panama who's in the hospital for prolonged fever for 6 weeks, a 6-year-old girl. These are right upper quadrant images, and you can see some cystic, weird ball structures in the liver. Yeah, this was good. This was a echinococcus. This was the first time we had seen this. And so the docs there were so kind to teach us a little bit more about it, showing this wasn't vascular. And I think we actually saw this again. We think that we saw this again in a patient in Malawi where echinococcus is also endemic to parts of Eastern Africa. So this was, again, a right upper quadrant. This was a patient who was severely wasted and had had prolonged fevers and had otherwise normal investigations. This was a transverse view, kind of where you would look at like the IBC, just looking at all these cystic lesions in the liver. So we were concerned that this was echinococcal, and if you have a little hard time remembering what echinococcal is, like I do, it is a disease born from dogs and also intermediate host in sheep, goats, and cattle. Humans are not an important part of the transmission, but they're a host. And so it can be asymptomatic, but it can manifest with all of these liver lesions. And so there's a whole slew. Ultrasound is very sensitive in the diagnosis. You could become an ultrasound expert just in echinococcal, but there's a whole lot of different findings you'll see of cysts in the liver. And if you're in an area that has echinococcal, it's worth looking into a little bit more, but kind of interesting cases.
I think this is our last one. So it's a 10-day, it's a patient with 10 days of shortness of breath in Malawi. So also a little bit swollen. So we looked at his heart, definitely very, very poor cardiac function, barely opening with those mitral valves. And then we saw this little friend over here. What do you guys think?
Yikes.
So whenever we see friends in the ventricle, we really just send the images to our friend, the cardiologist, because we never know if it's the papillary muscles or is it a thrombus or is what exactly is it? So what do you guys think?
That one looks like a thrombus.
Your guess is as good as ours. All right, but that cardiac function, then we assumed it was because of some stasis. Oh, actually, this was the last one.
Oh yeah, so this is something that if you are working in resource limited setting where you might see commonly. So we see a lot of kids with clubbing, and one of the lesions that they can have that is a survivable cardiac lesion is tetralogy. So you may end up finding some interesting images. And this was not a Down syndrome patient, but per like usual physical exam, but it's just an interesting image. You can see the nice generous right side and the big VSD and then the overriding aorta. So something that you'll probably see if you work in a setting where there's not a lot of cardiology or cardiac surgery.
Awesome. So any other comments or questions that you guys might have?
No, that was great cases. Thank you so much for presenting to us. This is fantastic.
Thanks.
Thank you guys for the invitation. We have fun sharing all this cases that we had no idea what they were.
We're usually stumped when we're in the moment, and then there's a lot of Googling and ultrasound and looking at case series. So thank you all for publishing interesting case series for us to learn from as well.
Yeah, thanks again, and look forward to having you guys back in the future. So thank you so much.
Absolutely. Thank you.